third important principle is optimal port position. I just mentioned a while ago that these working angles actually depend upon the port placement. So very important to understand and put the ports in the correct position. Wrong positioning of the ports is one of the most common causes of a stressful laparoscopic surgery. The surgeon keeps on struggling if the port position is not ideal. So, where to put the camera port and the working ports? So, the first port which you are actually going to put when you start your surgery is your camera port. Plan your ports wisely. This is the first decision which you have to make during that surgery, and this is the most important step of the surgery. Wrong ports, you will keep on struggling throughout the surgery because of poor ergonomics. So, optimal port position is going to ensure that you have the ideal working angles, the manipulation angle is correct, the azimuth angle is correct. Your own hand remains in a neutral position, adducted by the side of your body, and there is less clashing of the instruments happening either inside the abdomen or outside. So, various factors which have a bearing on your decision of port placement. Look at the overall body habitus of the patient. Is there a history of some previous surgical procedures being done on the patient? So, let me talk about the ideal position for the camera port. In laparoscopy, umbilicus is a very favored spot for all laparoscopic surgeons. It is considered the best site for putting the optical or the camera port. And there are reasons why we do this. This is basically because the umbilicus is more or less located in the central position of the abdomen. So if your telescope or the camera is going through the central part of the abdominal wall, it allows you easy access to all the quadrants. From there, you can operate in the upper abdominal, you can operate in the pelvic cavity, you can operate on the parietes also. And because the telescope is also going to be at the highest point, so once you're going to create the pneumoperitoneum and umbilicus being the central part of the abdominal wall, it will be at the highest point also. It causes less swatting of the telescope with the instruments. Ergonomics are very good. Additionally, since you're going to go through that umbilical scar, there are less chances of a port site hernia forming here. And obviously, that scar or the incision which you're going to give will be hidden in one of the umbilical creases. Your incision could either be transumbilical, it could be along the inferior crease, or it could even be along the superior crease of the umbilicus. But all these incisions would be camouflaged inside the umbilicus. So the cosmetic appearance is also good. Now, we also talk about this baseball diamond concept of port placement. And there are three rules which you must remember when you're going to put and apply this concept. The first rule tells you that laparoscopic instruments should behave like a type 1 lever. I'll explain what that means in a minute. The second rule is that the telescope should be in the center or in between the two working instruments. And the third rule, which I've already explained earlier, that the manipulation angle between your working instruments should be 60 degrees. So, what is this rule number one? It is telling that laparoscopic instruments should behave like type 1 lever. Now, a little bit of simple physics. A lever system could either be a type 1, type 2, or a type 3 lever system. It depends upon the position of the fulcrum, whether it is located in between the load and the force on the effort arm, or is it located on one side. So I'm just going to stick myself to type 1 lever. The best example of this type 1 lever would be a seesaw. And I am telling that laparoscopic instruments should also work like a lever. In fact, they are actually like a lever, because if you look at this image, half of the instrument is outside, and this is known as the force arm. Half of the instrument is inside the abdominal cavity. This is known as the load arm, just like any other lever. And liver has a fulcrum, and in our laparoscopic procedures, the port side where the cannula is going through the abdominal wall is your fulcrum. You are going to move your instrument around this fulcrum. And for the instrument to behave like type 1 lever, the fulcrum should be in the middle or in the center of the effort and the load arm. This is the best example of a type 1 lever. You see, this is a simple seesaw. One could be assumed to be the load arm, the other is the effort arm, and right in the middle you have this fulcrum. Same concept is applied in laparoscopy also. Why are we insisting on type 1 lever? Because if your laparoscopic instrument behaves like type 1 lever, which means in this case, half of the instrument would be inside, half would be outside the fulcrum. So when your instrument is going to be like a type 1 lever, then any force and movement outside which you're going to apply using your hand would be transmitted equally and in an opposite direction inside. So the movements in laparoscopy, if you realize, are counterintuitive. Unlike in open surgery, if you're holding a scissor and if you want to cut something on the right side, then you will move your hand towards right. It is the exact opposite of this in laparoscopic surgery. If you want to move the tip of the instrument which is inside towards right, the hand which is outside and holding the instrument has to move towards left side. So the movements in laparoscopy are counterintuitive, and because of that, we need the instrument to behave like a type 1 lever. So that if I'm moving the instrument outside by 10 degrees, it moves exactly by 10 degrees inside also. Otherwise, it will become very difficult for us to operate. So this is the concept of type 1 lever. As again I was explaining, the length of your instrument is going to be 36 centimeters. That means 18 centimeter of the instrument is inside, 18 is outside the abdominal wall. The fulcrum is going to be your abdominal wall port. So what does this mean? This means that for the laparoscopic instrument to behave like type 1 lever, your port position should be correct. And that port has to be at a distance of 18 centimeters from the target of your surgery. So automatically when you put that instrument inside that port, the instrument tip would reach the target of surgery with only half the length of the instrument. That is again 18 centimeters. So this is the concept of or rule number 1 of our the baseball diamond concept. Now, trying to put everything together, how are we going to put it into practice? So first of all, take the telescope inside, locate the target of your surgery. Now, every surgical procedure has a defined target. Target is identified as the area where you're going to do the most crucial step of the surgery. So for appendectomy, the most crucial step is ligating the base of the appendix. So the target would be the base of the appendix. In a lap chole, the target is the cystic pedicle, not the fundus of the gallbladder, not the Hartmann's, not the CVT. It is the cystic pedicle. For a splenectomy, the target of surgery would be the hilum of the spleen. For a TLH, the most important step is dealing with the uterine artery, so we consider it as the target of surgery. Go and identify the target of surgery with the telescope. Find out the length of the instruments. For adult patients, you would be using a 36 centimeter. Then draw an imaginary arc on the abdominal wall at 18 centimeters from the target and place your working ports on this arc. So this animation will help clarify what I am trying to convey here. See here, this is an example of a lap appendectomy being done. This is the target of my surgery. So my telescope is going to go through the umbilicus. I'm going to locate the target of surgery, draw this imaginary arc of 18. Now when I take my telescope in, my instruments in, you will find that I have already attained the ideal working angles. So angle between this instrument and this instrument now would be 60 degree. The azimuth angle here would be 30 degree. Because I have placed this port at 18 centimeters, see this is the arc of 18. So because this port is at 18 centimeters, so only half the length of the instrument would be in, the rest half would be outside the abdominal wall. Instrument automatically starts behaving like a type 1 lever. And this port has to be 7.5 centimeters away from the telescope port on either side. And I mentioned earlier, if it is 7.5 centimeters, automatically this azimuth angle would become 30 degrees. So this is the concept, the science behind the port placement in laparoscopic surgery. So ideally, this is the rule number 2. It states that the telescope should be in between the two working instruments. And this is known as contralateral port position. Please do not confuse this contralateral. It has got nothing to do with the site or the side of the surgery. Contralateral here refers to a position in which you have a telescope, and then the left and the right instrument are on the left and the right side of the telescope. This is what we mean by a contralateral port position. And why are we insisting on that? Because if the telescope is in between the two working ports, it will see both the instruments equally well. So it is more closer to our binocular visions. And we are insisting on that because this gives us better depth perception. Now, this brings me to another very, very important aspect of minimal access surgery. And we all know this, you must realize this, that there is lack of depth perception when you're going to operate laparoscopically. This brings us to the next principle of visualization. So, minimal access surgery is also known as image guided surgery because you are actually going to see an image on the monitor and you are going to operate looking at that image. Hence, we call it image guided surgery. Most of the times, you will see a system which is going to give you a 2D vision. Although 3D laparoscopic systems are available, they were introduced many, many years back, but they did not took off well. There are certain issues, the limitations of minimal of 3D laparoscopic systems, so they did not become very popular. So conventionally speaking, when you're doing minimal access surgery, you will be looking at a 2D image. This image on the monitor will not give you a depth perception. Now, this is drastically different from how we do open surgeries. In open surgeries, we are operating in a three-dimensional space and using our own stereoscopic binocular vision, we have depth perception. In laparoscopy, we are still operating in the same 3D space, three-dimensional space, the abdominal, the pelvic cavity. However, we are looking at an image on the monitor which is only two-dimensional. This confuses our brain. So with practice, you start understanding the depth. The surgeon needs to develop this cognitive depth perception. And how do you gain that? How do you start estimating the depths? By the use of depth cues. There are subtle signs which our brain recognizes, and we are familiar with those signs. So once I tell, then you will immediately realize that yes, we are making use of these signs subconsciously also. So these are some of the important depth cues. If you're looking at two objects and one object is nearer to you, the other object is behind the first object, you will automatically know that the object which is behind, because it is blocked by the object in the front, that the object behind is at a further distance away than so the one which is completely seen is nearer to you, the one which is occluded is at a further distance. Relative size of the object, anything which is closer to you appears bigger, anything which is far, far away from you will appear smaller. This is nothing but a depth cue. Look at the shadows. The shadow is always below. That means wherever the shadow is, that is going to be the lower part of the object. So so we are used to this, isn't it? We are always used to finding our shadows on the ground. Sun is up. So automatically we know, or our brain understands what is the correct orientation of that image. Not only these, there are multiple other depth cues. Contrast gradient. Anything which is closer to you, the objects which are closer to us, they appear to have better colors and contrast. The colors fade out as the object moves away and away from it as the distance increases. Excuse me. Texture gradient also improves. You can see more details of the object in the image which is closer to you. Similarly, as the object moves away from you, there is a linear parallax. There is convergence happening. Then there is motion parallax. Any object which is closer to us appears to move faster as compared to an object which is further away from you. You can all recollect from your train journeys or car journeys The trees right next to your car appears to gush past your window, whereas the large hill appears to move slowly, or the buildings they appear to move slowly. The buildings are farther away, the trees are closer to us. These are standard monocular depth cues which we must also understand in minimal access surgery. This is how we start appreciating the depth in a 2D image. Having said that, I mentioned that there are 3D systems which are also available. So here the surgeon can wear these special 3D goggles, and looking at this 3D endovision system, you start getting a depth perception. Not only this, nowadays in minimal access surgery, we are trying to improve the quality of the image in many, many different ways. And augmented reality is one of those methods by which you can actually superimpose the 3D reconstructed images of the scans live during the surgery over the organs. So this is especially important when you're going to operate upon liver tumors, especially the ones which are buried inside the liver lobes and cannot be appreciated from the surface. Then also there is this fluorescence guided surgery which has come up in a big way. We are going to use certain fluorescence dyes which are visible only with this near infrared wavelength. There are various modes. This is the standard mode of fluorescence guided surgery, and the dye is the indocyanine green. So wherever you are going to inject and the dye is going to be present, that area would be seen as green under near infrared light. You also have some other modes which the software generates. This is known as the black and white or the spy mode. So again, the contrast is more. You can see whatever is white is being outlined by the fluorescent dye, and whatever is black, that area is not highlighted by the fluorescence. This another way of looking. See how colorful the surgical images are now becoming. This is all software generated. It is basically telling us the intensity or the concentration of the fluorescence dye or the ICG. So this is using a thermal representation, just like a thermal photography. Wherever in thermal imaging, wherever the temperature is high, that area appears red. The areas with low temperature, they start appearing bluish. We are using the same concept here, but using it for fluorescence. So wherever the fluorescence is going to be high, that area appears red. Wherever the fluorescence is less, that area appears yellow, green, and then blue. This is the color segmented fragmentation mode, different modes of fluorescence guided surgery. Just to quickly show you how we are making use of all these modes. So fluorescence guided surgery can help you. This is the SPY mode. It can help you assess the vascularity of the tissue. We are doing an anastomosis here, and I'm interested to know, does this area has good blood supply or not? This is where the fluorescence guided surgery comes into picture. So you can use different modes here. These are all available at your fingertips with the press of a button. This is the CSF mode, and you can see red indicates very good vascularity. Okay. So on table, you are assured that the anastomosis which you are going to do here has good blood supply and very, very less chances of a leak because of ischemia. So advanced imaging modes of visualization are also available.